Hello, everyone. My name is Tristan Moore. I'm the program coordinator for the CARE department, the Community Awareness Resources and Education program here at Heartspring. And today we have Kori Visor-Lawrence talking to us about audiology and autism. So go for it, Kori.
Well, good afternoon, everybody. Like Tristan said, today I'm really just going to be talking about where audiology and autism intersect. So what an audiologist can do for you if you have concerns about those aspects of your child. So we'll get started. I always like to start kind of with my reasoning for getting into this. This is my little brother. He's now 23. He got his first big boy job, but he is an autistic person. He's the reason I started the path down audiology. He does not have hearing loss, but I thought, oh, I want to be a speech pathologist. That didn't vibe for me. So audiology, here we are. But he's one of the reasons that I work at Heartspring and I specialize in working with the autistic community. Here's a photo of him crying at my wedding. Look how sweet he is. I graduated from Wichita State in May of 2020. I've been at Heartspring ever since. And then there's a cute little picture of my dog that I had to add because look at his little face. Okay. So like I said, today we're going to talk about how audiology fits into auditory spectrum disorder. I do like to make a note that I try to use language that the autistic community prefers. So I may say autistic person instead of person with autism, just because that's what our advocates in the community are saying. I try to be sensitive to that. I'm not always perfect, but I'll do my best. So anyway, we're going to talk a little bit about audiology in general, how newborns hearing screenings work, when you go in to get your autism diagnosis, why we rule out hearing loss, how we rule out hearing loss, what that looks like for you. If we do find hearing loss, options for treatment. At the end, I talk a little bit about help with sound sensitivity, which is something the autistic community tends to have issues with, and then also some auditory processing stuff at the end. So the state of Kansas requires all newborns to have a hearing screening when they are infants. This started in about 1992 universally. Every state does this. And Kansas, if you were born in a hospital, you'll usually get that done before you leave the hospital. If you're born at home or with a midwife, typically they'll send you to someone who can do the screening, or they do the screenings themselves. This way, we're able to catch kiddos who are born with hearing loss and then get that follow-up started right away. In most situations, we try to at least identify by 1 month and then start treatment by 3. So that way we can get those really good early first year things done with the hearing aids or implants. So a little bit about pediatric hearing loss. At birth, about 1 in 3 to 1,000 children are identified every year. That does go up a little bit from 3 to 17. That's about 5 in every 1,000 children. And then there's also some recent research that came out that suggests about 1 in every 53 autistic children have hearing loss. So it's not a huge portion of that population for autism, but we can really run into that often. And one of the reasons that we might run into that is underlying genetic conditions. And I'll talk a little bit about that as we get down to the higher risk factors for hearing loss in general when it comes to kids. So prematurity, born before 37 weeks, that auditory system just didn't mature completely, or didn't get developed completely in utero. If there was a NICU stay longer than 1 week, family history of hearing loss, hyperbilirubinemia, I almost never say that right, but if we had high bilirubin levels, that can affect the inner hair cells of the cochlea. And certain infections, CMV, meningitis, herpes, if any of those things are passed through the birth canal, that can greatly damage the hearing system. Ototoxic medications, if they were given any sort of myosin drug, if they were in the NICU or had an infection. So we like to keep track of that. And then any underlying genetic conditions. And these can be trisomy 21, Treacher Collins. There is a huge list that hearing loss is associated with. So if there is any underlying genetic conditions, we will look at the hearing. Now, sometimes hearing loss is the first thing that will get noticed. So as a pediatric audiologist, if I find hearing loss in a newborn or a kiddo under the age of 18, I will always suggest genetic testing because ears, kidney, and heart all develop at the same time within utero. So if there's something wrong with the ears, there can oftentimes be something wrong with the heart or with the kidneys. So we like to look at that genetic testing and have those things looked at just to make sure everything's good. So that's just kind of how we catch kids early. But as we're looking into getting an autism diagnosis, the first thing that any provider will say is, well, we need to rule out hearing loss. So if there is a speech delay, that typically equals a hearing evaluation. So what does a hearing evaluation look like for a neurotypical child? We'll do otoscopy, we'll take a peek in the ears, make sure there's nothing blocking. We'll do tympanometry. And tympanometry is just a middle ear test to see if there's any fluid or current infection happening within the middle ear system. We'll do otoacoustic emissions. Now, this is the same thing they do at the newborn hearing screenings. Essentially, we put a little bit of sound into the ear, and the cochlea, which is our hearing organ that looks like a little snail, when that is functioning normal, it sends a signal back out, and we measure the strength of that signal. So that's how we can test babies without them having to raise their hand. And then we'll get into behavioral testing. Now, this looks different for every stage and age group. The first thing I do at about 6 months, we can start getting behavioral testing. And that's what we call visual reinforcement audiometry. And that is the top photo there. You see that little box that has lights in it. So what we'll do is we'll play a really loud sound that we know the kiddo should be able to hear. We will present the fun light up toy at the same time. And then eventually, once they understand, every time I hear the beep, I get to see the toy. Then we will present the beep, wait for the look in the toy, and then we know that they are responding to the beep. And then we'll turn that volume down and see if we can get thresholds within normal limits. Condition play audiometry, you can start that depending on where the child is developmentally, about 2.5. And that is the bottom photo. You see that little guy there with the pegboard. He's got one up to his ear and he's waiting for the beep. Every time you hear the beep, you're going to throw the block in the bucket. You're going to stack the peg on the pegboard. So we make it fun, a little more interactive. And then there's just traditional audiometry. Raise your hand, press the button every time you hear the beep. Now we can get these tests very reliably with neurotypical developing children, and often very reliably even with not neurotypical developing children. It takes a lot of work sometimes, and especially if there are sensory issues with wearing headphones or getting things into the ear, we can run into some issues, but sometimes it just takes a little bit of practice. And sometimes I'll have a kid come into the office and we have to practice, 3 or 4 separate appointments before we can actually get in and get the results that we're looking for. But once we get it, results stay pretty reliable. Now, there, of course, might be times where we cannot get behavioral testing and there's a major concern for hearing loss. So in that case, we would do what we call auditory brainstem response testing. And this little guy right here is most likely sedated, not asleep. We can do this on infants under 6 months because we can get him to stay asleep long enough. But if we get older and we can't get the child to stay asleep, we'll typically do this in a hospital setting. So he's got little electrodes on his head and some inserts in his ears. So what they will do is we will play a sound through the insert the electrodes will record the response within the brain, and we can get estimated hearing thresholds based off of those responses. Some kids with ASD, this is all we can ever get because there are sensory issues or the inability to understand the task that we need them to do during behavioral testing. There are a couple of places in Wichita that do this auditory brainstem response testing. Both of them are the hospital, Wesleyan Via Christi. I have some great colleagues over there who do this work. Hopefully Heartspring, within the next couple of years, we'll get a machine and start doing this, which is very exciting, but fingers crossed for us. So like I said, typically this is sedated. Testing is usually pretty short under sedation. We can get things done under an hour. So the kids are not under very long, and it gives us estimated thresholds. So it may not be completely perfect, but it would be enough for us to fit a device or rule out hearing loss if there's not hearing loss. So this is just a little bit of the basics for types and severity of hearing loss and what we look for when we are looking for hearing loss in any child. This is the same with neurotypical and non-neurotypical children. So sensory neural hearing loss, this is the typical hearing loss you'll hear of in the older population. So it typically results in damage. Now this damage can happen even from birth if the hair cells within the cochlea have not formed correctly, or if the cochlea didn't form correctly. So again, this is just damage. It's permanent. Not much you can do to change it. Then the second one is called conductive hearing loss, and conductive hearing loss typically happens due to middle ear issues. Now this could be malformations of the middle ear, infections, diseases. An ear infection really can change a child's hearing by about 40 decibels if it's a really thick mucousy infection. But conductive hearing loss is usually not permanent. It can usually be managed through medical management, whether that be PE tubes, surgery, or medication. So the third one is called mixed hearing loss, and it's a mix of the two. So you could have sensory neural hearing loss in your high frequencies and then have a conductive hearing loss in your low frequencies. And we have a special test that we do to tell the difference between the two. I'll talk a little bit about this chart I have here. So this is a typical audiogram, and this is what audiologists and ENTs use to plot hearing loss. So we can see it on a graph. Down at the side, it says soft to loud. So 0 decibels all the way down to 120. Excuse me. So anything above 20 decibels, loudness wise, is completely normal. Then we get down into the severity of hearing loss. So mild, moderate, moderately severe, severe, and profound. And these all have to do with how loud you can hear the test stimuli. So across the top is pitch. So it goes from really low pitches all the way to high pitches. So I don't know if you can see my mouse here, but sorry about that. But right here in this range is typically where speech sounds are. So if we do have hearing loss in that area, then speech is going to be delayed. You can also have hearing loss in these low frequencies, and then speech can be delayed there as well. But really what we want to look at are those high frequencies when it comes to speech development. So we do have a couple options for treatment. These stay pretty consistent for our neurodiverse and our neurotypical kids, but of course we can do hearing aids. That's usually the first thing we shoot for. They can be fit very easily through whatever we find on the audiogram. We can even fit hearing aids with just a couple of frequency thresholds, and that's what's recommended by ASHA. We also can do cochlear implants. Now, cochlear implants, the loss has to be pretty severe to profound in order for a child to be a candidate. But even before they're a candidate for cochlear implants, in most situations, we fit a hearing aid first, just to try to get some auditory stimulation to the cochlea and to the brain. And then, of course, families always have the option to not do anything. If the family does not want to choose any kind of intervention, then you can use sign as the primary communication. Now, that is fairly difficult in some situations. If a child is born into a deaf family and that's already their mode of communication, easy peasy, they're welcome to make that decision. But most children, about 70% of children who are deaf, are born into a hearing family. So the hearing family probably doesn't know ASL. Now it's very possible for the family to learn, and those are all options. You can use both. If you want to do hearing aids and ASL, totally up to you, and totally up to the audiologist that you're working with. So for our neurodiverse population, if this is a route we have to go down for fitting any sort of amplification, there are a lot of management techniques for retention. And I hear a lot of parents say, well, my kid's not going to keep that in their ear. There's no way this is going to happen. Now, it does take some coaxing. Luckily for us at Heartspring, we do have a great psychology, behavioral development staff who are willing to help with those retention issues. I have a little guy I'm working with right now who he wears them for 45 minutes, gets them off for 20, puts them on for 45 and gets them off for 20. And eventually we'll be stretching those stretches longer to hopefully we'll be getting him to wear them all day. There are also equipment that can help the retention. So there are headbands that can go on. So if a kid does fling one out, it's attached to the headband or attached to a clip on the back of the shirt so we don't lose them. Pediatric audiologists, we have quite a bit up our sleeve for those little things. So there's all options, and the worst thing we can do is try and have it not work. So we'll always try in that case. So the next thing we're going to talk a little bit about is hyperacusis. Now, this is a sensitivity to everyday environmental sounds. It's estimated 50 to 70% of autistic persons exhibit symptoms related to hyperacusis. Now, the hyperacusis, much like autism, is a spectrum. Some people are going to be a little sensitive when they hear something they don't like, and then on the other hand, we're going to have the complete and utter meltdown when we hear the fire alarm. Now, we know due to research that this has more to do with brain function and less to do with how our ears function. So there's been a lot of testing on neurotypical and non-neurotypical people. And what we see is that it has more to do with the situation and the environment and less to do with what the ears are actually hearing. But fun fact, autistic persons are 500% more likely to have perfect pitch than neurotypical people. So I learned something new today when I found that out. I was like, oh, I didn't know that. So there are differences, but most of it has to do with brain and not actual ear function. And one of the reasons we think that is, specifically in autistic people, is the amygdala is more on edge. So they did some brain scans, and when an autistic person heard a sound that they didn't like, and one of the sounds that they used was wool scratching together. You know how horrible that sound is? They played that sound and did an MRI. And in the autistic person, the amygdala lit up. And the amygdala is, famous for our fight or flight response. So this just increased this fear response when we heard the sound that we didn't like. And again, every person is different. So it could be, it could be the fire alarm, it could be the trash truck, it could be the vacuum, whatever that is. So we are still doing a lot of research in this area because there's a lot that we don't know and we don't understand about it. Now, typically for treatment, occupational therapy is your go-to for that specific treatment. In a lot of ways, it looks like cognitive behavioral therapy. Some will do exposure therapy, so just exposing ourselves to the noise and creating a safe environment where that happens. But there is a huge gap in research for treatment. This is an area that I think we need several different disciplines working on, including audiology. But it'll be interesting to see where this goes. So my next slide, we're going to talk a little about what you can do at home for hyperacusis. Every child, like I said, is completely different. But these are just some steps you might be able to take for whatever is happening with your child. So number one is identifying the irritant. So what sounds are uncomfortable? Examples can be the radio, the school alarm. Just make note of that, especially if you live in a noisy household. Which thing is actually setting our child off? Could be multitudes, but something to just identify. Number two, we're going to create quiet time. So audiologists and speech language pathologists and OTs typically discourage the overuse of earplugs and headphones or noise canceling headphones to avoid the sound sensitivities. But I will acknowledge that their noise canceling headphones can make a very big difference if we are in a super overstimulated state. If we're having full meltdown because the tornado siren is going off, that might be an instance where we use that headphone. But using them constantly can actually increase that fear response to whatever sound is bothering you. There's still a lot of research, like I said, that's coming out about this. But if it's a necessity and there are other battles that need to be fought at the moment, the headphones can be used, but I would discourage some of that. So noise breaks, create that quiet time in your house. If you have to take a noise break for 20 minutes, no TV, no iPads blaring, we keep it down. Creating that quiet time can make a really big difference in bringing that anxiety lower. Identifying quiet zones. So where are places that are naturally quiet and comfortable for your child? This could be, the library, it could be an art class, could be a sensory room that you have in your home or a sensory room that's at school. Those places are going to be really important for your child to go to and to decompress. Number four is creating distractions. So when trigger noises are unavoidable, like we know the trash truck is going to come Monday morning at 9 o'clock, we can use a distraction. So whatever that distraction may be for your child, favorite toy, iPad, and using a good distraction when a loud sound is happening may actually keep our anxiety down and then thus make us not be as sensitive to that particular noise. Number four, we're going to observe first. So if you know you're going to go somewhere where something is going to be loud, before that exposure happens, allow your child to listen to the noise from afar. Use opportunities to familiarize your child with whatever sounds are going to be coming, and that kind of will help reduce the shock of when the exposure is right in their face. So, if you're, let's say, going to take the kids to a movie, let us maybe stand in the back or stand a little bit outside of the theater to get that noise first before we go in and sit down. So just creating some space might be very helpful. Six is creating some control. So adjusting certain sounds and giving your child control to adjust those sounds can be very helpful. So for instance, turning the vacuum cleaner on and off, so they know that there is an off button. So give them the chance to do that. Or, let them sit in the car and honk the horn. So let them have control over whatever noise they're making, and give them the space to do those things. And then eventually, hopefully you can gradually raise the exposure to whatever that noise is. So every child, again, is completely different. And for some children, I know I have seen children who wear noise canceling headphones most of their day because that's their main sensory issue. Again, an audiologist can help you identify some of these issues, but a lot of your treatment is going to come from your occupational therapist. So just a place to look. So the next thing we're going to talk a little bit about is auditory processing. So auditory processing in general can only be diagnosed by an audiologist. And auditory processing is what our brain does with what our ears hear. So this little picture that I have, this little snail-shaped thing down here at the bottom, that's your cochlea. This is the auditory pathway that runs all the way up to your brain, to the auditory cortex. Now, these little stoppage signs, those are major areas within the auditory cortex. Now, there can be a problem at any of these areas. The issue that we have with auditory processing is we can't exactly identify where that is happening through behavioral testing. There's a lot of research coming out with EEGs, some acoustic response, so where we might, and imaging, so we might be able to see where the issue is actually happening, but we have a long way to go. If you do believe your child has issues with processing, and a lot of the times what that looks like is not being able to understand speech and noise, asking for repetition, or completely seeming to ignore you. Those are kind of two different things, but processing, again, is nothing wrong with the ear, but what is happening in the brain. If this is something you have particular concerns about, there are audiologists, myself, who will test kiddos with autism. There are several audiologists that will not, but there are a few of us that will. Your child does have to meet the qualifications. They have to be able to sit through behavioral testing. I can cut down a lot of that behavioral testing, but they do have to be fairly high verbal. They would have to repeat words back to me that I say. And in some cases, I know that's not an option. But if we are on a more high verbal side, then that is something we can look a little bit more into. Several of these kids have problems with phonemic awareness and reading and writing, and attention sometimes is balled into that. But two of the main things that we see, especially with autism and auditory processing, is what we call binaural integration issues. So that is listening to something on this side, listening to something on this side, putting them together and having them make sense. And on the other hand, we have binaural separation issues. So having noise come at you from each side and being able to pick out the really important parts, like speech. So many of these kids will have major problems understanding speech and noise. And these are just associated symptoms. Now, having auditory processing does not cause autism, but they can be linked. Still a lot of research happening with where that's happening in the brain and why it's happening. But we do know that there's a link. There is also a link with auditory processing with ADHD and dyslexia. So these things are all happening within the same area of the brain. We just have to parse out, is it a true auditory problem or not? So there are ways that we can improve auditory processing if we can find the deficits through behavioral testing. Here at Heartspring, we offer the Phonemic Training program, and that is specific to phonemic awareness. So telling the difference between B and D, and also knowing that B is ba, D is da, and telling the difference between the two of those things. So we'll do a lot of that kind of work. Also work on listening to speech and noise, and we can target some auditory memory if auditory memory is an issue. There are several online therapy programs that have been successful. Just depends on the kid. Can we do it at home? Is this going to work over the computer? I would say this is better for my probably 10 and up age range. But there are lots of strategies for success, and we can implement those strategies. I'm sure most of those strategies are already implemented on IEPs, but there are ways that we can help a child with auditory processing succeed. Just a little picture here. These are just some of the issues that we can run into, but that's kind of what that looks like. So I just gave a short overview of several things that the audiologist can do for you. If you have concerns about your child's hearing, please give us a call. Also, please be aware that there are several audiologists who, not pediatric audiologists, who say they can do lots of hearing tests, but you have to know what accommodations to give non-neurotypical people. I work with, not at Heartspring in our outpatient, but also with our residential students. And I have residential students I've never been able to test that I go and see every other week, just so we can be friends. So they'll let me touch their ears. So sometimes it does take a lot of work, but we can definitely get there given the time. So if you've been unsuccessful with hearing evaluations in the past and you would like to try something else, give us a call. We'll do our best. And if not, we'll refer you to someone who can do that auditory brainstem response testing. If there is a major concern, those are options that we have. So my contact information is here. My email, you can get that from Tristan. If you have any questions, even about processing or hyperacusis or anything else ear related, please shoot me an email. I love to hear from people and talk about audiology. So thank you, Tristan, for having me.
Absolutely. Thanks so much, Kori. That was very informative. I think it's going to help a lot of families. So thank you so much. And I hope everyone enjoys.